So I think we are currently focusing a lot on the female aspects of infertility, but a word on the male aspects of infertility. Is there a biological clock for men? Is in a similar way?
There are 30 to 40% of infertility cases that are because of the male factors. One of the most common causes in India is polycystic ovarian syndrome.
So there must be obviously studies that have looked at the long-term outcomes of IVF babies versus natural babies. Are they any different when they reach their teenage or adulthood?
Sadly, in India, still there's a big taboo on infertility, and it's still, taken as a personal failure rather than, treating it as a medical condition. 40 to 50% of infertility cases are because of the female partner.
Hello and welcome to Conversations at Shyam. In this episode, we will be talking about a rising issue of the modern world, infertility. Today with us, we have Dr. Shailee, who is an obstetrician and gynecologist and an expert at infertility management. Welcome to the podcast.
Hello, thank you.
So to begin, the first question that I'd like to know is, what is infertility?
It's a very, defined term. Infertility is something when a couple is trying without using any protection for at least a month of 12 months. For a period of 12 months. That's when you can label somebody having infertility.
Well, that's interesting. You mentioned two things there. You mentioned the duration, that it has to be at least 12 months.
Correct.
And without protection. So,
correct.
If say a couple is married for 6 months and they are not able to conceive, you would not label that as infertility, is it?
Yes, technically that is not termed as infertility.
All right. We hear a lot about infertility these days. Is there a reason why we are hearing more and more about it? Is it just awareness, or is the incidence also increasing?
Well, the incidence of infertility is increasing a lot in India nowadays. There are a lot of factors, lifestyle being the foremost, late marriages, late conceptions, and also decline is seen in the AMH levels post the age of 35.
Right.
And this is, that decline is very rapid these days. So these are the few reasons why infertility is on a rising trend.
Okay, so you mentioned a couple of things there. You mentioned an age cutoff of 35. So, is it a recommendation that the biological clock is real and that if one does want to conceive naturally, that there is a appropriate time frame in which that conception should happen?
Well, definitely the biological clock is real and it is ticking. And having said that, the lifestyle or the timing used to be different previously. We used to say as gynacs that it was best to conceive in your late 20s. But of course, with the changing era, we do still prefer that the patients do conceive in their early 30s at least. Because specifically in Asian population and Indians, we have seen that the AMH tends to, drastically have a dip or fall after the age of 35.
Oh, that's very interesting. So, say for example, somebody is looking for the right person, the right partner, hasn't conceived, or they have certain career goals that they wish to achieve and they don't want to conceive. Is there an age you would start recommending them to get their AMH levels done?
Well, yes. So first and foremost is the awareness that you need to take care of your fertile health or your ovarian reserve is something that you need to think of way prior before you think of all of this. So yes, if your future is unclear, say professionally or personally, we do recommend that in your late 20s you get you go visit a gynac, you get your ultrasound done, you see the ovarian reserve, and you also check your AMH levels. If you see a decline or you see lesser amount of follicles in either of these studies, then yes, you must discuss the future options that you have. Now with newer technology and so many advances in artificial reproductive techniques, we do have options of egg preservation and embryo preservation and planning your pregnancy or timing your, family planning accordingly. Right.
Excellent. That's so there is a possibility of being able to balance your career, your aspirations to find the right partner as well as preserving your fertility, which is great news.
Yes, with the right awareness and the right guidance, it is.
Yeah. Now, going a little bit into the specifics of the ultrasound that you mentioned. So, is there a cutoff of the number of follicles you would like to see? Is there a cutoff of the AMH levels that you would like to see?
Well, that depends on the age again.
Okay.
So, with newer guidelines and everything, it's very specifically given for, an age group of say 20 to 30 years old. We expect the antral follicular count, that is the baseline ovarian reserve that we see on day 2 or 3 of the cycle,
Okay.
to be more than 20.
Okay.
So, more than 20 follicles in both the ovaries is a
Right.
good count.
Right.
Say that starts declining from say 30 to 35, we expect it to be between 10 to 20.
Okay.
And again, all of this is very subjective,
Right.
and it depends on patient to patient, on their cycle patterns, on their AMH and AFC levels.
Right.
And saying all of this, this is only the quantitative analysis. There is unfortunately still no way in, that we are able to reach the quality of the eggs or determine how good the eggs are in their quality.
Correct.
So all of this that we can judge is basically on the quantity and not the quality.
Correct. So I think we are currently focusing a lot on the female aspects of infertility, but a word on the male aspects of infertility. Is there a biological clock for men? Is in a similar way, and is there like sperm preservation or something like that? Does a counter part of the ovarian preservation or embryo preservation exist?
Well, not a biological clock per se, but yes, male infertility is a completely different topic.
Right.
And when we talk about infertility, we're talking about infertility of the couple and never of the female or the male part.
Correct.
You'd be surprised to know that 40 to 50% of infertility cases are because of the female partner, but there are 30 to 40% of infertility cases that are because of the male factors.
Right.
So there are a lot of factors, and that too also because of the lifestyle.
Right.
Say smoking, alcohol, very hot temperatures, and there are conditions like varicoceles, and a lot of drugs, a lot of pesticides and plastic use. All of this in the in this generation is leading to a lot of rise in male infertility.
Yeah, I am not surprised to know that because I am a urologist and I also deal with male infertility. So I think for today's episode, let's focus on the female aspects of infertility.
Right.
So what are certain diseases that make a person prone to infertility? Are there any diseases within gynecology or overall as part of the systemic health of a person?
Yes, so definitely. One of the most common causes in India is polycystic ovarian syndrome. You won't believe it, but 1 in 5 females, suffering from infertility do have some amount of PCOS.
Okay.
And that is one of the most common reasons for infertility, where they have very irregular delayed cycles, where there's anovulatory cycles, or the ovulation doesn't happen on time. So all of these factors are what is responsible for the infertility in that case.
Okay.
Another rising reason is endometriosis.
Right.
So, for those who don't know what endometriosis is, it's the endometrium that sheds every month, that is found inside the abdomen, somewhere near the tubes and the ovaries and even the bowel and bladder. So, that is something that leads to a lot of pain during the cycles, pain otherwise, also difficult sex. So, yes, endometriosis is another rising cause of infertility.
Right.
Yes, of course, obesity and male factors, as we talked about, are other causes. And there's a chunk of around 10% cases that are still, undiagnosed, and we don't know the cause of infertility, that we term as, idiopathic causes.
Correct.
So, yeah.
Right, very interesting. Now, there is one other thing that gets talked about very often. Is there a correlation between how frequently the couple is having intercourse or having sex and their chance of conceiving? Because in the urban population, with all the stress of the modern life, the frequency of intercourse has also significantly gone down. So if you look at rural India and if you look at urban India, that difference is drastic. So is there that sort of thing?
A little bit, but still, it is mainly the unawareness of the fertile days.
Right.
And that's a very individual thing. And for every female to know, that their own fertile days is very important, because all of the other days, even if they try, there's going to be no point, because it won't help conceiving.
Correct.
Because once you ovulate, your egg is only alive for 24 hours.
Right.
So,
Correct.
and the sperms or the semen is alive for like 72 to 96 hours,
Correct.
right?
Yes.
So, to know that window in the whole month, some people, when they have like a 45 or 60 days cycle, it becomes very difficult to pinpoint those days. And
Right.
of course, their chances of ovulation annually, like say somebody has a chance of ovulating 12 times a year, that also goes down in PCOS patients when they have irregular cycles.
Correct.
So, not the frequency, but the right timing does matter.
Absolutely. That's a very valid point. Now, going a little more into the details of the timing. So, is there a way in which the couple can know what are their fertile days? Are there markers? Are there apps that are available on the phone, etc.? I've heard a little bit about that.
So apps, I'm not a big fan of.
Okay.
Because sometimes they are a little misleading.
Okay.
And I've seen a lot of patients, struggle because they are trying to, read the app correctly or get their timings right because of the app.
Okay.
But I've seen that not work at times. Yes, there are luteal phase kits available in the market, the LH kits.
Okay.
But again, they are not very sensitive.
Right. Okay.
So one very easy method that people can use at home is actually first and foremost knowing their last 6 months of cycle.
Right.
And having an average pattern.
Okay.
And if you minus like 14 days, that's the luteal phase of every cycle.
Right.
If you minus 14 days from your average cycle, those are your fertile days generally.
Right.
So yes, there are basal body temperature rise, and there is a vaginal mucoid discharge and all of that. But again, all of that is very subjective.
Very subjective,
And
yes.
people might not know. The easiest and the most confirmative way would be by a follicular study, where the patient comes, visits a gynac, and we do an ultrasound and we check for the follicle and check when it ovulates.
Perfect.
That's like the 100% most guaranteed way to know what's happening.
All right. So now let's dive into the infertility management. The cycle that would follow once a couple is rather labeled as infertile, then what does it typically look like for them?
So basically, as I told you, if a couple has, very genuinely tried for 12 months and did things in the right way, and still they're not able to conceive, yes, they do need to, figure out what's wrong.
Right.
So the first step there is a female ultrasound and a male semen analysis. Are these two things that need to be done to rule out the basic reasons for most.
Yeah. So I think just stop you there for a second. So it is both, right? It is semen analysis and a female ultrasound. Any other blood tests?
Yeah, so that depends again on the history. But yes, thyroid function tests, prolactin, other hormones, the baseline hormones that need to be done early in the cycle, and an ultrasound. Everything together. And of course, as we talked about, AMH.
Yeah.
So AFC and AMH together gives us a lot of clue about, how much time do we have, or what is the ovarian reserve of that female.
Yeah.
That's not the only aspect we look at, but sadly in India still there's a big taboo on infertility, and it's still taken as a personal failure rather than treating it as a medical condition.
Correct.
So yes, male infertility is a big part. We still see that in our practice, that the males are hesitant on getting their tests done, and they feel like everything is okay on their end. So yeah, it's both of them.
Correct. So I think what you've alluded to is very important, that the male aspect of infertility should not be ignored. There is a taboo around infertility which needs to be dealt with. We need to ensure that when a patient comes through our door for infertility, we are supportive not just from the medical standpoint but also from the emotional standpoint, because I think it's a very emotionally disturbing and challenging journey for a lot of couples to go through the infertility journey. And there is a lot of social pressure also that comes in. Now, I often tell the male infertility patients that we see at Shyam Speciality Hospital that don't discuss this outside your very close circles, because everybody is an expert in how to
Yeah.
make kids, especially in India with all the population that we have. But is that something that you would agree with? That obviously you seek support in people you think are like-minded and would be able to support you,
Correct.
but not discussing this outside your close circles?
Well, definitely. I see this in my practice that I generally see the mother-in-law and the daughter-in-law coming for infertility treatments.
Okay.
The husband doesn't even come to the consultation sometimes.
Okay.
But yes, now times are changing. The younger population is open and aware about this.
Right.
And, they are as much involved as the female better
Yeah.
half. So, yes, they... most of our IVF sessions or your infertility patients, the majority of it is counseling.
Right.
And telling them what is the right way of going ahead.
Right.
Because, with social media and so many apps around you, people want things instantly.
Correct.
With this also, they have a thing that it should be instant. The
Correct.
month we try and we should be able to conceive.
Right.
So the first thing I tell my patients is you have to give this time. You have to give your doctor some time to understand your cycle and to give you what is best for you.
Right.
So, that impatience sometimes leads to over-treatment in infertility as well.
Correct.
So, go step by step. And I tell my patients that first we'll just, we see your cycle, we do your basic tests. If they look good, we go ahead with a simple follicular study for a few months. If that doesn't work, then you step up the treatment to whatever's next. You check for the tubes or you do an IUI. Yeah. And then is the step of IVF. Yes, sometimes you do, jump to the last step because you know that would work and something else would not.
Right.
But, every time that it happens, it's not actually necessary.
Correct. And you spoke about only the daughter-in-law or the daughter and the mother-in-law coming to the clinic. I think with male infertility, the male ego takes a big hit when you talk about male infertility. But it is very important to mention here that male infertility does not make anybody less of a man. So it is not that, it's an attack on the manhood in the eyes of a lot of people, but it is not true. Like, because if you get a fracture, you don't become lesser of a man. If you get a kidney stone, you don't become lesser of a man. Similarly, your femininity is not compromised if there is infertility. It's a problem that has come up it could be because of various reasons. And it should be looked at as a problem that now has excellent solutions.
Correct.
So let's dive into those solutions now. Anything else that you want to talk about in the diagnostics before we jump into the treatment side of things?
You wouldn't have thought about this 10 years back, but now we have such good technology to the level where you can actually biopsy the embryos and know whether they are good genetic material or not, whether they are euploid or aneuploid, or which is the best embryo to even transfer, So all of this can be done before you can get pregnant as well. So we've reached that technology, not that everybody needs it, but times have changed. And at least to be aware of what all is available and what are your scopes or what are your chances to get pregnant, I think we've come a far way.
Right. So, talking more about that aspect of things, about selecting the embryo and all, there is this myth that babies that are conceived through IVF or infertility treatment, any form of ART, are different from kids that are conceived through natural conception. Any truth to that, or?
Different, no, but there is a misconception where people think that the chances of abnormalities in those children are more. Yes, because they are artificially, when you inject a sperm into an ovum, you are artificially doing it and it is not a natural process.
Correct.
Having said that, no, there are a lot of, confounding factors in this. Increased maternal age anyways leads to more abnormalities and aneuploidies in the baby. Of course, when you don't genetically test those embryos, of course, there is a chance, but that is also because of a lot of confounding factors and not just the treatment per se.
Correct. So, there must be obviously studies that have looked at the long-term outcomes of IVF babies versus natural babies. Are they any different when they reach their teenage or adulthood?
No, so nothing really. There's no difference.
There's no difference. No. So IVF babies are just as good as naturally conceived babies. So the whole idea of natural is better is probably not true over here. Excellent. In terms of the genetic testing of the embryo, etc. Can you speak a little to that? What happens and why are we doing it? Are we like designing babies? Are these designer babies? What's happening there?
So what I was talking about is PGTA,
Okay.
that is pre-genetic testing of the embryos. Basically, that is done in specific cases, which is increasing nowadays for patients or couples who have had multiple recurrent miscarriages, have had abnormal babies in the past, or recurrent implantation failures. When you have multiple embryos, but you want to pick the best out of the lot, there's something called PGTA, where they take a few cells from the trophoectoderm and they are genetically tested to see whether that embryo is genetically normal or not. And once they find out that it is a euploid embryo, those are the embryos that are picked to get better live birth outcomes.
Correct. Okay, excellent. Very interesting. So it seems like the technology is getting safer and safer, and the results are also probably improving, are they?
Of course, yes. So there's no comparison. They are improving because a lot of these things were not available a decade back.
Really?
So yeah. So of course, the chances of live birth rate in infertility treatments have increased drastically after all of this. And even with male infertility, there are a lot of now surgeries or microsurgeries that help with, getting sperms from even a patient with zero sperms, or azoospermia as we call it. So yes, so having your own biological child has become, like, the rate has improved drastically from the past. Yes.
All right, excellent. All right, so now let's dive into the treatment side of things. Say, for example, a woman has PCOS and it has come to you for infertility treatment. Then how does the treatment go?
Right. So one of the most common causes, as we mentioned. So basically, you go stepwise. Okay. If the patient has come to you at a reasonable age, of course, a PCOS patient will have a higher AMH in general because they have multiple follicles. That is what the etiology is.
Right.
So that is generally not the problem. The problem here is anovulation or delayed ovulation. Right. So the first step generally is, seeing the male factor. If that's okay, we don't take that into consideration and we move ahead with the PCOS per se. Ovulation induction with the right drugs. We now have superb injections for the same. We generally start with aromatase inhibitors like letrozole with HMG or FSH, and then you just track the cycle. You see when the egg is getting ready and getting ovulated. You ask them to try naturally for a while, with a follicular study in the background, and like, see, a few of them will conceive with this. Somebody with an AMH very high, these drugs are not working on them, they're resistant to these drugs. There are two ways to go about it. One is you can opt for PCO drilling. That is, we make small holes on the ovary to make them more sensitive towards these hormones, and that's called a drilling method.
So that would be laparoscopic, right? The ovarian drilling?
Yes. So you do a laparoscopic, diagnostic laparoscopy with hysteroscopy. You look at everything else. If there are, the ovaries are bulky, not responding to hormones, you, do 4 to 5 drills in each ovary. And that makes them more sensitive towards the hormones, and they are better responsive to treatment then. And of course, IVF is an option. So you will get a lot of multiple eggs. That's the hope with PCOS patients. And so that is how you go about with a patient like that.
All right, interesting. So when does IUI come into the picture, and who are the right candidates for something like an IUI?
Yeah, so basically IUI is done for multiple factors. One of the main factors being male infertility. So a partner having a substandard count, not that low that the patient will require IVF or ICSI, but lower than normal, or the motility is affected in some way. In those cases, like a borderline low count is something where an IUI can do wonders. It is also done for cervical factors, or when there's a lot of painful sex and the patient is not able to try and conceive in the right days. these are the conditions where an IUI can actually help.
Correct.
So it's basically a step up from follicular study, and it's a step below IVF. That's
Right.
where it stands.
Okay. So now, how does the typical IVF cycle look? And if you can allude to a little bit of the cost of IVF cycles, and how many cycles does it take for a couple to conceive? What is the success rate of each cycle? All these standard IVF questions that don't always get the right answers to.
That's a podcast in itself.
Okay.
But yeah, we can. So a standard one cycle of IVF in Ahmedabad, or say in India, is approximately 1.5 to 2.5 lakhs.
Okay.
Depends again. It's very subjective and depends on a lot of other factors.
Right.
But somewhere between this range.
Okay.
For IVF, we generally say that if you get 10 good eggs,
okay,
if you can retrieve 10 good eggs, you are confirmed at least one live birth. Like that's an average ratio that we talk about.
Right.
Because if you get 10 eggs and you fertilize them via ICSI or anything, and you let them grow to day 3 or day 5 embryos, you keep losing those. Like for anything to reach day 5 embryos, we say you'll get approximately 4 or 5.
Okay.
And out of them, when you do an embryo transfer, we generally say 4 day 5 good euploid embryos will give you at least one live birth.
Right.
So the chances, that's what the IVF labs also say, that they are around 50 to 60%. The
50 to
success
60%
rate
per cycle, or is it overall?
Yes, no, 50 to 60% per cycle.
50 to 60% per cycle.
Yeah.
Okay, that's very encouraging.
Yeah.
So if it is say 50 to 60% per cycle, and you unfortunately fall in the rest of the 40% who haven't conceived through that cycle, then what happens next? How long do you have to wait? What is the protocol?
Yeah, so generally there's no wait.
Okay.
If you, if that IVF cycle didn't work for you, the next very month, if you have euploid embryos that are still there and preserved in the lab, you can always opt for a second transfer.
Right.
So we generally say 1 or 2 embryos to be transferred at once. Of course, more than that is anyways not allowed. But you discuss with your fertility specialist on whether a single embryo transfer or a double embryo transfer is the way to go.
Right.
Opinions might change and you can have your own perspective to it, but it's 1 or 2. So basically every cycle gives you around 50% chance. So that is how you go about it.
So you spoke about ICSI. Now, what is the full form of ICSI and how is that done? What is it?
So basically ICSI is a type of IVF. Where like a type of fertilization that is used in IVF, that is intracytoplasmic sperm injection, where a robotic arm catch holds of a morphologically normal looking sperm and artificially injects that inside the egg,
right,
for fertilization to happen.
Correct. So even if the motility is say compromised, even then ICSI would work.
Yes. That's the aim.
That's the aim. All right. So it's been a very informative podcast today, and we've spoken about female infertility and gone into the details of how you can prevent female infertility in a way, what we can do to diagnose it, what are the diagnostic tools available, and certain treatment options that are now available for female infertility. We're very happy to share that at Shyam Speciality Hospital, we cater to both the female as well as the male side of infertility through the team that we have here, and we would be very happy to bring you more educational content around urology, gynecology, and hopefully if you have any questions, we'll be able to answer those as well. So leave those questions in the comments below. You can directly message us on our social media pages, and we'll be very happy to share our knowledge with you. Thank you. Thank you very much, Dr. Shailee, for being part of this educational podcast.
Thank you. It was wonderful being here.